Okay, picture this. You're standing in a high-stakes delivery room. A newborn has literally just been delivered. You quickly note a heart rate of 120 and acrocyanosis, those blue hands and feet. The clock is absolutely ticking, and you have to act right now. So what is your first priority as the nurse? Do you suction the airway, or do you grab a warm towel to dry and stimulate the baby? Go ahead and lock in your answer, because this exact scenario, it trips up thousands of nursing students every single year.
Welcome to this explainer. I am seriously thrilled to have you here today. Our goal is crystal clear. We are going to master newborn care priorities and totally outsmart those tricky test traps you're inevitably going to face. We're building powerful visual memory anchors today, so when you finally sit down for that exam, the right answers are just going to jump right out at you.
So here's our game plan. We'll start with the NCLEX newborn trap, move into priorities covering APGAR and airway, break down normal versus abnormal assessments, discuss feeding, meds, and bonding, tackle a priority NCLEX clinical scenario, and finally finish up with a rapid-fire NCLEX recap. Let's dive in.
Section 1. The NCLEX Newborn Trap, Spotting the Difference.
Listen, examiners absolutely love to test your ability to differentiate between two very specific conditions, caput succedaneum and cephalohematoma. You've really got to chunk these in your memory. Caput succedaneum, that's just a soft edematous mass. It's basically swelling of the soft tissues from the sheer pressure of labor. It's a completely expected finding, and it resolves entirely on its own in just 3 to 4 days. No treatment needed. But cephalohematoma, that is a completely different story. That is an actual collection of blood trapped between the periosteum and the skull bone, usually the result of birth trauma, like a really difficult labor or a forceps delivery. Because it's blood, it takes way longer to resolve. We're talking 2 to 8 weeks.
What's really crucial here is how the edema of caput succedaneum physically crosses over the infant's suture lines. It isn't restricted by the skull bones at all. A really great memory trick for this? Just think of a cap. A cap covers the entire head, right? It crosses over all the lines.
Now, contrast that caput with a cephalohematoma. The blood here is strictly pooling within the boundaries of the suture line. It does not cross over. And why is that? It's because the bleeding is happening underneath the periosteum of that one specific skull bone. Just remember, hematoma literally means blood, and that blood stays put on one side. Do not fall for this trap on test day.
Moving right into Section 2, Priorities. APGR and airway, the golden first steps. So, getting back to that hook question from the very beginning, you absolutely must clear the airway first. The golden sequence is suction the mouth first, then the nose, and only then do you dry and stimulate the infant. Why? Well, if you stimulate a baby who still has amniotic fluid or mucus hanging out in their mouth, they're going to take a massive gasp and aspirate all that fluid straight into their lungs. Quick mnemonic for you. M comes before N in the alphabet. Mouth before nose, always.
Right after that, we're evaluating their transition using the APGAR score. I really want you to focus on the heart rate metric here. If it's absent, it's a 0. If it's slow, specifically below 100 beats per minute, it's a 1. And if it's above 100, it's a 2. Let's do a quick pause and think. Why is it absolutely critical to distinguish if that heart rate drops below 100? It's because a normal newborn heart rate is 110 to 160. Anything under 100 is a massive red flag telling us this baby is struggling to transition and needs our intervention right now.
Section 3. Normal versus abnormal assessments. Recognizing red flags. Let's chunk these normal vitals together so they become a single visual memory anchor. Normal temp, 36.5 to 37.5 Celsius. Heart rate is 100 N to 160. Respiratory rate is 30 to 60. Now, pay super close attention to this next point. Newborn respirations are naturally irregular, sporadic, and shallow. Because of that, you absolutely must count them for 1 full minute. No shortcuts. Also, acrocyanosis, those blue hands and feet, is totally normal for the first 24 to 48 hours. Don't panic, and whatever you do, don't call the provider for blue feet on day 1.
Okay, so the flip side is knowing exactly when you should panic. Massive trap alert here. While blue extremities are perfectly fine, central cyanosis, meaning a blue chest and face, is a huge red flag. If you see nasal flaring, if you see tachypnea over 60 breaths per minute when the baby is calm, or if you hear grunting and see chest retractions, you must intervene immediately. These are textbook signs of acute respiratory distress. It means the lungs are failing to do the work they just took over from the placenta.
Alongside breathing, thermoregulation is your top priority. There are 4 distinct ways a newborn loses heat: convection, evaporation, radiation, and conduction. Remember why we dried the baby way back in step 3 of the transition? That was to prevent heat loss via evaporation of the amniotic fluid. And why do we immediately place the baby skin to skin and swaddle them in warm blankets? To stop heat loss through conduction to cold surfaces and radiation to a chilly room. If they lose heat, they burn through their oxygen and glucose incredibly fast, and that leads to a really dangerous downward spiral.
Section 4. Feeding, Meds, and Bonding. Supporting the new family.
You are absolutely going to be tested on these immediate interventions. Vitamin K has to be given within 1 hour of birth. Why? Because a newborn's gut is completely sterile. They don't produce their own vitamin K until around day 7, so they're at a super high risk for bleeding. You've got to inject 0.5 to 1 milligram directly into the vastus lateralis muscle. That's the meaty part of the thigh because their other muscles just aren't developed enough yet. We also track output rigorously to make sure they're getting enough nutrition. You should expect them to pass meconium within the first 24 to 48 hours, and they should be voiding 6 to 8 times a day by day 4.
Now let's pivot to the mother's psychological transition. You need to be able to recognize these phases of maternal role attachment. The taking in phase always happens first. For those first 24 to 48 hours, the new mom is dependent. She's focused on her own basic needs, like food and sleep, and she really needs to talk about and process her birth experience. So don't expect her to master newborn care right out of the gate. That comes later, in the taking hold phase, usually around day 2 or 3. That's when she suddenly wants to take charge, practice caring for the baby, and really learn from you. Knowing this timeline is key to providing the right support at the exact right moment.
Section 5. Priority NCLEX Clinical Scenario. Putting it to the test. Let's walk through this scenario carefully. A 2-hour-old newborn has a heart rate of 150, a respiratory rate of 65 with grunting, and blue hands and feet. Pause for a second and think, what is the priority concern here? Let's break it down together. Heart rate of 150? That's fine. Normal is 110 to 160. Blue hands and feet at 2 hours old? That's just acrocyanosis, totally expected for the first 24 to 48 hours. So the real priority concern here is the respiratory rate of 65 combined with the grunting. That is tachypnea, and it's a major red flag for respiratory distress. Airway and breathing are always your top priority.
All right, Section 6, Rapid Fire NCLEX Recap. Let's lock this all in. Fact number 1. Acrocyanosis, those blue hands and feet. This is a completely expected finding for the first 24 to 48 hours of life. It is not central cyanosis. Please do not get tricked into calling the provider for this. Fact number 2. Fontanelles should be soft and flat. If you assess bulging fontanelles while the baby is calmly resting, that's a massive red flag pointing to increased intracranial pressure, an infection, or a hemorrhage. On the flip side, if they're depressed or sunken in, you're looking at dehydration.
Fact number 3. When you're clearing the airway at birth, what is the sequence? You always suction the mouth first, and then you do the nose. Remember our trick. M comes before N. Clear out that mouth before they gasp and aspirate.
And fact number 4. A cephalohematoma involves blood trapped between the periosteum and the skull. Because it's bound by that periosteum, it will never cross the baby's suture line. It stays put on one side. If the swelling crosses the line, it's just a caput succedaneum. And just like that, we've reached the end. You've now got the memory anchors you need to master the healthy newborn transition. But wait, what happens when maternal complications arise before the birth even begins? Well, we're going to tackle preeclampsia and fetal monitoring next time. Until then, keep reviewing, trust your training, and I will see you in the next explainer.